back. We are going to continue our discussion of glucose regulation. And we are going to start out today by talking about hypoglycemia. Hypo meaning low, glycemia meaning blood glucose. And so we know that the brain has an urgent need for glucose regulation because it cannot produce its own glucose. So when we have someone who is hypoglycemic, when their blood glucose is less than 70, they may be symptomatic. And symptoms might include shakiness, dizziness, sweating, headache, sudden changes in behavior. They may become confused, they may become irritable or agitated, they might feel weakness. Again, they might get sweaty or diaphoretic, that's another word for sweating, and they may become extremely pale, so pallor. And so if you think about it, rather than just trying to memorize the symptoms, I want you to think about how the lack of sugar in our brain might cause us to feel dizzy or confused or irritable, right? Or shaky, right? Think of a time when maybe your blood sugar was kind of low. I think we've all maybe experienced that at one point or another. And you can think back and you can look at this list and think, I think I've experienced some of these things. I felt kind of weak in my body, or I have been what we call hangry, meaning that we are so hungry that it changes our behavior a little bit, right? Now, of course, the thing about a diabetic is that, they may become hypoglycemic, and usually they are definitely aware of these types of symptoms, and they will go and they will get something, maybe something to eat, whether it's a sandwich or a snack, and they will immediately feel better, very much like us, if that would be the case. However, when we're taking care of diabetic patients as nurses, we have to be monitoring them for these symptoms. And if we identify any of these types of symptoms, what do we need to do? Check their blood glucose. Absolutely. That is always going to be the number one intervention that you want to do in a diabetic patient who has any kind of change in their status. Check their blood sugar. So, what causes hypoglycemia? So, we talked a little bit just now about not eating. Well, what do we frequently do to people that we put in the hospital? We make them NPO, right? No food or drink, nothing by mouth. And so we need to be careful about doing this, especially in our diabetic patients, because it puts them at an increased risk for becoming hypoglycemic. Of course, reduced oral intake as well. In the case where a diabetic has an illness and maybe a loss of appetite, they're not feeling well, they're not eating, they are going to be at a risk for becoming hypoglycemic. Okay? That's why it's important for our diabetic patients to get their regularly scheduled meals and snacks. Other causes of hypoglycemia are that if there is an interruption of enteral nutrition. And so here we have an example of an individual who is getting a tube feeding. And so that tube feeding is being given through a tube that is connected into their stomach. and maybe something happens and there's an interruption of the enteral nutrition in the diabetic patient and puts them at a risk for becoming hypoglycemic, okay? A mismatch in the timing of food intake and the peak action of the insulin that we give. So I'll give you an example. You've got a woman in the hospital. She is a type 2 diabetic. Some type 2 diabetics that are in the hospital will be put on a sliding scale insulin, meaning that we will check their blood glucose fasting in the morning. And based on that blood glucose, we will give them some insulin before their breakfast tray comes, okay? If I were to give a patient their insulin and then there was something wrong with breakfast, either that the trays were delayed for some reason or there was a problem with the patient's breakfast and it had to be sent back to the dietary area, then we would have to be careful, right? Because if there's a mismatch in the timing of the insulin and the insulin peaks, right, and the patient has had nothing to eat, right, then they can become hypoglycemic. And so it's really important when we're taking care of patients that we keep these things in mind. Exercise can cause hypoglycemia. Diabetics really need to monitor their blood sugar when starting an exercise program. And so what that means is until they are aware of how whatever exercise they're going to do impacts their blood glucose, they probably need to check their blood glucose before they start exercising, check their blood glucose maybe midway through whatever their routine is, and then check it again. And get an understanding for how they can have a safe blood glucose level while they're also, taking their medications to keep their blood glucose down as well, right? Because so they're taking medications to lower their blood glucose, they're exercising on top of that, and these can lead to episodes of hypoglycemia, okay? We talked about before that hypoglycemia can be dangerous, can result in loss of consciousness, seizures, coma, and even death. And so what are we going to do about it? All right, so in a clinical setting, if our patient is awake, we can give them 15 to 20 grams of a carbohydrate. And examples of this might be half a cup of juice or maybe 8 ounces of low-fat milk. Candy bars, cookies, ice cream, no, should be avoided in a hypoglycemic situation. Fat will actually slow down the absorption of the sugar, and so we really want to avoid that. Something very simple like some juice or some milk or some crackers will be perfectly fine. But again, don't forget, after we do an intervention, after we give them something, we have to remember to recheck the blood glucose. However, if the patient is not awake, then we can administer IV dextrose. We can give them glucagon IM or subcutaneously. If they are not in a hospital setting, we can give them an injection into their muscle of glucose. Oftentimes, patients will carry glucose tablets around. This is another way to get a little bit of glucose in them. They can have glucose tablets, and they usually know how many glucose tablets they need to take to raise up their blood glucose to a safe level. So remember, to recheck the blood sugar in 15 minutes. We always want to explore the reasons why the hypoglycemia occurred. It might be a good time for patient teaching as long as the patient is, awake and alert and stable. We want to kind of try to explore why this happened and try to help them figure out ways to keep this from happening in the future. So, we're going to take a little bit of time here and talk about some of the treatments for insulin-dependent diabetes mellitus, or type 1 diabetes. So, clearly we see insulin is written in great big letters because, well, you tell me. Oh, very good. Because type 1 diabetics don't make insulin, okay? You can see here that diet control is a very small in writing because even though it is important, it is not as important as insulin. So, there are different types of insulin that we give. There is a rapid acting, such as Lispro. There is short acting insulin, like regular insulin and Humalog. There is intermediate acting or medium acting, like NPH and Lenti. And then there's long acting insulins, like Lantus. And so when we talk about this different types and whether they're rapid, short, or medium acting, what we're talking about is how long they are working inside the blood to help control the blood glucose. And so we might give regular insulin in the morning along with some NPH or medium-acting insulin to our patient in order to give them a little bit of extra insulin for the meal that they're about to eat, and then that longer acting, that medium acting insulin will continue to help keep their blood glucose in a good range throughout the morning. Okay, and so here at the bottom we see some of these combinations. We see a type of insulin that's 70% medium acting and 30% regular acting. And so these are different types of insulin. Insulin schedules can really be designed around the patient's ability or their willingness for compliant. And so what we mean by that is if you have just one daily dose of a long-acting insulin like Lantus or Lenti, what that's saying is that it has kind of a basal coverage, meaning that it can help control the blood sugar for 24 hours, all right? So this might be a simple way of controlling the blood glucose. A more moderate type of insulin schedule might be to give twice a day dose of a medium-acting insulin like Humulin N insulin. So maybe you wake up in the morning and take a dose of Humulin insulin, and then you take another dose later in the afternoon. That's BID, twice a day. Or even more complex, which would be the addition of an AC and HS sliding scale with regular or Humalog, which is a short acting. What do I mean by AC and HS? Well, AC and HS means before meals and at bedtime. So AC before meals and HS at hour of sleep or at bedtime. And what a sliding scale insulin schedule might look like is what you see here. It says that if you check the blood glucose and it is between 200 and 250, then the patient is supposed to get 2 units 2 units of regular insulin. Okay? Here we can see that if we check the blood glucose and it is between 251 and 300, that we are ordered to give 4 units of regular insulin. And as the blood sugar goes up on the scale, so does the amount of ordered insulin. Okay? Notice at the bottom it says call doctor if greater than. And generally speaking, if the blood sugar is greater than 450, it's going to be important to notify the physician. Although I want you to critically think in your mind, would you give the insulin and call the doctor? Yeah, probably, right? If the blood glucose is greater than 450, we're probably going to need to be giving this person some insulin for sure. We're just also going to be notifying the doctor because maybe we need an adjustment in the amount of insulin that they're getting, okay? So, we can have a very complex type of insulin schedule, and that would be use of an insulin pump. So here we can see an insulin pump. It's got an indwelling subcutaneous needle into the fat tissue or subcutaneous tissue, and what happens is it is programmed to deliver a continuous infusion of insulin subcutaneously. Our patient can be taught to adjust the basal rate. So anytime you hear me say the word basal, we're kind of talking about continuous rate. And bolus doses, which are a single dose in time, that's what a bolus dose is, for exercise, illness, and in between meals if the patient is hyperglycemic. So, insulin pumps can be very helpful for really good glucose control, tight control of blood sugar. However, it does require frequent self-monitoring of blood glucose levels and meticulous care of the equipment, which is why it maybe isn't for everyone. The advantages of the pump therapy include greater flexibility in meal timing and content and greatly improved control of blood glucose levels. Okay? On the other hand, the person has to be pretty willing and compliant in order to take care not only of the equipment, but to monitor their blood sugar probably a little more frequently. The benefit is that they get better control. Okay, so insulin types. All insulin preparations begin kind of as regular insulin as the base. We want to think about it that way. Additives actually affect the timing of the release, all right? So additives can also cause allergic reactions at the injection site. And so it is important to think about when we are giving insulin that it's still most popularly given subcutaneously with an insulin syringe, a pump, or a metered dose pen injector. And we will probably take a look at what a pen injector looks like. You'll see these in the clinical setting as well. But what we kind of want to think about is how might we mix NPH and regular insulin in the same syringe. Now, we said that it may be that your patient might want to have a dose of regular insulin in the morning before their breakfast, but then they also take an NPH or a medium-acting insulin to kind of keep that control throughout the morning. But do we really want to inject them twice? No. what we want to do is to be able to mix those two types of insulin in the same syringe, okay? And so you will spend some time in lab practicing how to do this, but the rule of thumb is that we want to avoid mixing any of the longer acting or the medium acting insulin into the shorter acting insulin. Why? Because we said that the additives that are in the medium acting insulin are really what affect the timing. So if we get some of that into our short acting insulin or our clear vial of insulin, we could then be over time introducing some of that NPH insulin into the regular insulin, causing it to be no longer short acting, all right? And so in mixing, we want to draw up the clear before the cloudy, all right? The clear or the fast acting before the cloudy or the long acting. So you're going to be practicing this in lab, and we will be talking about this more. I want you to study this, though, in lecture because there will be a test question about this, I promise you. And classically, they like to ask these types of questions on the boards as well. So that is all I have for you today. I thank you for your attention. Until next time.